Okay, it's recording now. So again, for any disease, so I'm giving you now, these are the kind of templates of nursing questions for identification of patients with a high risk or the history or the related factor, the related to factor. The question will give you the clinical diagnosis of the patient and ask you what you expect to find when you review the patient's file. So for a patient with endocarditis, for example, if you see Crohn's disease, for example, or any GI or renal problem, has nothing to do with the endocarditis. You can exclude that, and then you have to distinguish the other parts and see which one is more really related to it. Okay, so focus on every time we talk about endocarditis, rheumatic fevers, and the beta hemolytic kind of infection. Okay, let's see. Thanks. Okay, so simply, by the way, the endocarditis there are different types of endocarditis, but the major type, or 90% of the cases, are infective. They're causing by infection. So that's our focus here. So as far as pathophysiology, again, simply it's starts with an invasion of microorganism that's most likely is a bacteria. Again, through procedure, dental procedure, or through IV drug abusers, and then the rest is a growth and colonizing of bacteria. The problem is when that takes place, the whole cascade of reaction between microorganisms and immune system is vegetation, which is colonization of bacteria, as well as when the platelets and white blood cells start also to attack and be in the area, that will lead to a formation of clots. So the problem is that you have thrombosis and you have vegetation. Okay, so these together, they affect mainly the valve movement, which will eventually affect the flow, the blood flow of the heart, and it will be symptoms just like heart failure. Okay, so mainly these patients, they have risk for thrombosis, and also there is vegetation. Also could be calcification, which basically these blood clots, when they dry up, they become very hard. And you saw that later in the valves when they're calcification, how that affects the opening of the valve. So eventually the valve destruction can be a result, which will lead to heart failure eventually. Now, this is a key word here because that's one way to diagnose endocarditis. This is something we can see on echocardiogram. This is another keyword where this patient is at risk for thrombosis, so they should be encomidin if this risk is there. And again, the valve destruction is our concern. So when you have a patient, for example, with endocarditis, until here, you need to understand the pathophysiology. Until here, what you would see in the patient, as far as symptoms, is fever, maybe white blood cells are high, and up here you will see vegetation echocardiogram. As this continues, and then it will eventually lead to valve destruction. Now, if you will replace these words with symptoms, you would say fever, leukocytosis, echocardiogram, and murmur. Murmur, every time there's a valve problem, that's mainly correlated with murmur, especially if it's a new murmur. So if you have a patient who comes with fever and then the next day or the next time you see them, you hear murmur, then that's a poor prognosis. That's a critical thinking. That's critical. So you have to look at this picture and you have to understand it. So whatever question you get, I know it's the stress of the exam sometimes, but this is how you have to train yourself how to think. When the problem gets to here, that's mean there's poor prognosis. When the patients start to show symptoms of heart failure, that's mean that that's a poor prognosis. So a patient was with leukocytosis and fever, and now they have murmur, or now they have edema or pulmonary edema. So you can see there's a progression. So that's another thing. That's how you need to read pathophysiology also. Okay. So Start with infection, fever, chills, and leukocytosis. These are not specific because you could see them in every infection, correct? So none of these are definitive. That's how we decide which, when the question asks you which of the following confirms, you're looking for definitive symptoms. These are shared with millions or with a lot of other diagnoses and infections. Okay, now the word vegetation, when you have a echo report states there's a vegetation on the valve, that's not shared with other diseases. That means one thing only. So this is how we say that vegetation of bacteria and one of the valves is a definitive sign of endocarditis. Okay. Okay. So valves, we talked about murmur, decreased cardiac output. Okay, and as you know that if now we talked about different type of valves, but the AV valves, the ones between the atria and the ventricles, are close also to the AV block. Sorry, to the AV nodes. So when there are problems there, it also affects the AV. So that's why one of the most common dysrhythmia, if the valve involved is the valve between the atria and the ventricle, AV valve, then the dysrhythmia that you would see will be AV kind of dysrhythmia, and that should make sense. So AV blocks first degree and second degree and third degree and so on. Okay. All right. So again, the symptoms, we talked about the vegetation or colonization, another word for that, of bacteria on valves. These are a result of, we talked about the thrombosis, and not all of these thrombi are large. Some of them are small, and so they can break. They can cause different symptoms. Now, the splinter hemorrhage, this one, as you see it, and we don't understand the exact mechanism, but this is one of the classical symptoms that you can see in endocarditis. So if you see this in NCLEX, any questions, it's mainly goes with mainly, you can see it with others, but in all the books that you can look at, medical and nursing, splinter hemorrhage goes with endocarditis. Okay, the other also classical symptoms that you only see them with endocarditis also is one of them Osler nodes, that you see them here. You see them in the feet and the palms, and these are painful red raised lesions. These are lesions, and again, hands and feet. And the other one is the Janeway's lesions, and these you see them also in the soles, mainly in the palms, and these are painless. Okay, that's one of the differences between them, because this one mainly it's really an immune reaction and affects the nerves. That's why it's painful. While the other type, it's more of lesion. This is more of skin or dermatology problems. But again, these symptoms you only see them in endocarditis. Okay, and then the last one is rough spots, which basically hemorrhage in the retina. Okay. And also it's correlated with endocarditis. Now, these are more of comprehension. Again, the comprehension, actually, this more will be more of memorization, because even the comprehension is not understood in these cases. There are some theories. So a question about this, an NCLEX question would be, which of the following is not seen in endocarditis, for example? So you may see, as far as options, root spots, as well as ulnar and Janeway, and in a fourth name that's not, or it could be, or it could ask you select all that applies and give you 5 options and ask you to select which one, that the ones that are considered to be classical or seen in endocarditis. Okay, again, the high risk group. It makes sense to see 95%, of course, fever, and this is an infection, as well as chills, murmurs, and 85%, because again, It's affect the valves. Now, not every endocarditis will lead to destruction of valves, but every inflammation of the endocarditis can cause some dysfunction, temporarily at least, where you will hear murmur. That's why 85% of these patients, they come with murmur. Okay, now this may go away if you get the patient on time and you treat the infection and the inflammation disappears. But if it's recurrent or if it's too late, it may lead to permanent damage. So all the symptoms that I just shared with you that are considered late stage. So how that can be, again, if the question give you any of these pictures or a description of these symptoms, now that you know that they are late stage, then they also indicates poor prognosis. Any symptoms that you see it in late stage, that means we are late. So it would be an indication of poor prognosis. As well, of course, the signs of heart failure. Now, did I talk about ejection fraction right now or no? But what if I ask you a question, which of the following indicates a poor prognosis or confirms or supports or indicates that the endocarditis has become complicated? That means you're looking for a late sign or you're looking for any sign of complications. So when I say here heart failure is the most common complications, and if I give you that question, ask you, look for symptoms or any indication that now we have a complicated case, and I give you ejection fraction of 35%, that shouldn't be foreign. You should get that, because I just, instead of putting heart failure, I give you a systolic heart failure, a number. So that's again another critical thinking. When you see the full picture, you need to measure every option and what they mean. Replace them with your knowledge. When you see ejection fraction of 35%, that must remind you that this is heart failure, systolic heart failure. So endocarditis can eventually lead to heart failure. There you go. Okay, so as you see, critical thinking is not something you can lecture about. It's really a skill that you will need to acquire and learn. Okay. Let's see. Okay, we talked about this. This is a medical criteria, so I don't care if you memorize it or not, because you will not diagnose the patient. Okay, but you must know that again, the criteria of diagnosis the patient is again when we do a blood culture. But remember, we said that blood culture could be false negative. So, but blood culture will help, of course, and the presence of vegetation echocardiogram as well as murmur. So you don't have to memorize it, but you have to know that again, this is an infection in the blood, so blood culture help. If there's a growth, it will be seen as vegetation, and if it affects the valve, then you will hear murmur in physical examination. Okay. And if the patient has rheumatic fevers before, rheumatic infection, then the RF factor or RA factor is seen to be high in about 50% of the cases. So as you see, what this means that 50% of the endocarditis are caused by an infection, by a rheumatic infection that the patient had before. Okay. Okay. Again, the other thing about medical management, now we know that every bacterial infection should be treated with antibiotics, but we talked about this to be a serious infection. So the treatment still the same, it's antibiotics, but not regular, which is what we talked about, high dose, bactericidal for a prolonged time and should be done through IV. So Now, you don't prescribe medication, but you should know this. So you may need to question an order. If the physician gave an antibiotics for 2 weeks, let's say, or a PO medication, or one medication only, you have to question that. The other thing is important to educate your patient. So you need to make sure that your patient understand this. It's very important, the adherence of the patient. So another way to ask, again, the template that we always use is, which of the following indicates that the patient understands the treatment? Okay, so if the patient says that I'm glad I can continue this medication orally when I go home, or I'm glad I don't have to do this more than 2 weeks, um, but the patient can go home and continue to take the IV. So the patient, it's okay with the patient, I'm happy that I can continue this IV drugs at home, and so on. Okay. The patient may ask you why he has to take a blood thinner. They must take multiple, at least two or more, between 2 to 3. Okay. Oral hygiene is extremely important for this kind of patients. So again, the prevention always focused. The kind of NCLEX question that you will see tells you that you are planning to do a teaching in the community for about endocarditis. Which of the following contents you must include in your education? And so one of the major thing, because you're not going to teach patient, you want to just teach patient about preventive measures. So we're not going to talk about taking medication. There's no immunization involved. Okay. So again, you have to have your knowledge. You understand today from pathophysiology of endocarditis that the oral care is the least thing that the patient can do, a non-invasive, something on their own to prevent or to reduce the risk of endocarditis. Now, so if you get this kind of question, one that I just mentioned, you're planning and teaching sessions about endocarditis. Now, one of the options was that you encourage the patients to take um, the annual vaccines, or the vaccines for endocarditis every 5 years. Now, if you don't understand it well, this option will sound good, right, for you, right? Because we talked about pneumonia, that one way to prevent pneumonia is to take immunization. One way to prevent the flu is to take immunization. Now, if you don't have the solid information, knowledge, and knowing that endocarditis is not something that you take an immunization for, it, you just stay away from it. It's not something that common. It's not like pneumonia and flu. So although this option sounds right to you, I'll take the vaccines. Yeah, why not? But we never talked about, there's no vaccines for endocarditis. So don't go with the option that sounds right. What you must talk about is mainly the oral care. So um, there you go. Nope. If you talked about vegetation in uh, the endocardium or the valve, it's mean one thing. It means one thing. Um, it means endocarditis. Yes, it's positive. Okay. Now remember that the patient doesn't come only with one symptoms. Okay. These patients, you hear murmur. When you hear murmur and you see the patient fatigue, and you find leukocytosis as well as fever, and then you see vegetation echocardiogram, then this will give you the full picture. It's impossible to have a patient with vegetation in their echocardiogram, and that's the only symptoms. Because if they have that, that means it's infection. Yes, so they will have all these other symptoms of infection as well. Okay. See. Any questions? on this module. Okay, and you got some questions here again. You can go back and redo them. Okay. Yep. Go ahead. Let me unmute you actually. Okay. Go ahead, Norma. Do you have a mic? We can't hear you. We can't hear you. You can go ahead and type it if you want. Okay, go ahead, Grace.
Is that why we give patients antibiotics prior to procedures to prevent endocarditis, or is this something that would have been caused prior to the dental work?
I'll answer your question just a second. Let's see. Okay. Okay. Again, no. Let me answer Grace's questions first. Now, if the preventive antibiotics that you give, you only give them for a patient with high risk. Okay, so it's not routinely that you go every time you need to have a dental procedure to take antibiotics. But if the patient has high risk, if they have a valve that's inserted to, or if they fall in one of the group risk, they have to take. Okay, so the dose that we give before the problem, it's a prophylactic. Now, it's usually could be one single dose. In fact, the dental procedure, you can only give it PO. You give the patient just 5 days of PO medication of antibiotics before the procedure. It's not of course, it's not the therapeutic one. Now, for normal questions, no. In this case, the patient have to continue and to complete the medication IV. They can go home and continue. Now, what you will notice in the hospital, the patient may come with pneumonia, their symptoms are okay, they've received maybe 3 doses of IV. Now they can go home and they could continue their medications PO. We can switch them. But in this case, because of the seriousness of the infection, because it must be eradicated, we have to complete the course of antibiotics through IV. Now, again, patients can go home with their PIC line, and there are special companies that insurance company contact, and they will be sending nurses to their homes every day to give them the IV dose. So it has to be all done for 6 weeks at home. If they want, I mean, yes, it has to be IV, not PO. Okay. Okay.
That's
All right.
3 antibiotics, right?
Okay. Two to three antibiotics. 2 to 3 depends on the microorganism. Okay. The other modules is the pericarditis. So again, the same way, the same template. You need to remember, where is the problem? What is the location of the problem? It's the pericardium. Now we went from the inside to the outside. The pericardium, this membrane, the major function of it is actually to protect the heart from infection, and it also has a lubricant. So every time the ventricles and the atria contract, to prevent the friction, we have that small amount of lubricant fluids between the pericardiums and the heart chambers. And you see that everywhere in the lungs and everywhere, wherever there's organs move, like in lungs, you need some lubrication around so to prevent the friction. So that's one thing. And again, the other thing is to prevent the heart, the infections from the surrounding tissues or organs, like from the any infection that can affect the lungs or the thorax. The pericardium will prevent that infection from spreading and reaching the heart. Now that's the pathophysiology. Sorry, that's the physiology. Now the pathophysiology is that, as you see here, there is the pericardium should be at a specific layer, specific size, and if it's inflamed, or if the pericardial sac or the fluid inside the pericardium, that should be a very small amount, increases, then basically that will restrict the movement of the heart. As simple as that. So it's a restriction of the movement of the heart. In other words, the heart will not, the filling volume of the heart and the ejection volume will not be normal as a result of that. So that's in general anatomy and physiology and pathophysiology. So let's see. Okay, as an infection, this as age, just like endocardium, could be infectious, could be non-infectious. Most cases are infectious, and most infections are actually caused by viruses, not, but it also could be bacterial and fungi. But there are other cases where that can lead. Now, the inflammation is mainly a result of infection. So when it's when it's infective pericarditis, it's mainly caused by infection. But remember the fluids, the lubricating fluids, whether it's in the lungs or it's in the heart or anywhere, the volume of that depends on the maintaining a normal osmolality or concentration of body fluids. Okay, so if that changed because of medication, let's say, or because of, like in case of increase of uric acid in the blood, so the changes in concentration between the intracellular and the extracellular can lead to edema. And we notice that in pulmonary edema, we notice that in heart failure because of the, when you see the peripheral edema and so on. So the changes in the permeability of the blood vessels, where there will be some shifting of the blood volume to the interstitium, that can also increase that volume in the pericardial sac, and that also can cause the same problem with pericarditis. You could see it in MI as well, in cancers, especially in the thoracic area, whether it's lungs or breast, and some surgeries, radiations, and so on. Okay. So again, regardless of the etiology, whether it's an infection or a change in the permeabilities, there is an influx of fluids and as well as an immune reaction. That will change the permeability of the blood vessels, leading to inflammation and edema or leak of the blood volume or some of the blood or water, of course, from the blood, causing edema, which will restrict the heart. Now, the restriction here, it's again because of the inflammation. So it has the symptoms that you will see. First, it has to do with the inappropriate or inadequate filling of the heart chambers. So preload and afterload will be affected. Also, anything that apply or add pressure on the heart will cause pain. Now that pain is reported as chest pain, but it is not it's non-cardiac because it increases with pain, with breathing. So every time the patients breathe, the inflation of the lungs will also add more restriction on the heart, and that's lead to pain as well. So that's, we talked about how to differentiate cardiac from non-cardiac. But in any case, the contractility of the heart will be weak because of the restriction. The cardiac output will be weak because of the restriction. Restriction will lead to low preload and low afterload, or sorry, low cardiac output. Also, another classical symptoms that you would only see it in conditions that restrict the movement of the heart, such as pericarditis and cardiac tamponade, is muffled heart sound. Okay, so we talked about that to be one of the area or one of the symptoms that can confirms the presence of endocarditis. So when you hear muffled heart sounds, you know that the pericarditis reached to the point that it's severely affecting the heart. And of course, with that, you will see hypotension. You may see tachycardia though, but definitely see hypotension. If we do an echocardiogram, you can clearly see that there's inflammation around the heart, and you can see that ejection fraction is low. Now, the ejection fraction here is low mainly because of this restriction, not um, necessarily because of like in heart failure. Now, when again, this is the late symptoms, but the other thing about the late symptoms, if you again, the logic goes, when there is a late symptom, it means poor prognosis. When the late symptoms is reverse, it means good prognosis. So let's say you have a patient with pericarditis and now you hear muffled heart sound. And the other template of question is how to evaluate a treatment. So we have a patient with pericarditis. We give them, the medication, all the thing that we need to do. And now you are reassessing the patient, and which of the following indicates that the treatment has been successful. So when you look, especially when in these cases, I give you before and after, when you see that the ejection fraction moved from 25% to 35%, that's not enough. Although it moved up, but doesn't mean that's been successful. But if the question tells you the patient has muffled heart sounds and now they have prominent or like clear heart sound, well, that's a good indication. Or if you see a strip of ECG where the QRS is short, and we talked about that short QRS as a result of weak contractility, and now you can look at the same patient, but now when you look at the new ECG, you can see that the QRS is back to normal height. That's a good indication. Now I could reverse it and say which of the following indicates that treatment has not been successful. So I will give you what was good and not what is bad, for example. Or if if the ejection fraction is still low, that means that the treatment has not been successful again. So keep these areas that we focus on as your template, and you can fit in any problem that you lead in the the height of the QRS. We said if you see it longer than normal, that's usually an indication of hypertrophy. And if you see it shorter than normal, that's indication of restriction and the heart movement. Okay, let's see. Okay. The other piece is again pericardial friction rub. Every time again you see this is a perfect match with pericarditis. You only hear pericardial friction rubs. Depends on the wall and the wall. Depends on what wall you're looking at. Depends on what lead you're looking at. But I either will give you the measurement or will say it in words, short versus high, or you just need to look at and compare two different strips. Okay. So the pericardial friction rub is abnormal sound that you only hear in pericarditis. Another thing we talked about. Okay, here's another. Remember we talked about the pleural effusion. We talked about pleural friction rub. Pleural friction rub, we find that in a pleural effusion. Now here's is the same kind of problem, but it's around the heart, not the lungs. Okay, it's coming. It's coming. The pericardial friction rub is in the pericardium, and you will hear it with if you assist the pulse at the same time of the patient. So if you put your hands on and assist the radial pulse of the patient, and at the same time listen to the friction rub, you will see that the pericardial friction rub correlates with the pulse, because that's when the friction and this leather rubbing, it's mainly the heart against the inflamed pericardium, while in the pleural effusion it had to do with the breathing, not with the pulse. So that's another way to differentiate between pericardial friction rub and a pleural friction rub. Now we talked about the pain, and it's correlated with, again, with the lungs being inflamed. It's important to know, like, again, the position of the patient. When you have the patient lead forward in an upright position, this will help with the pain relief of the pain temporarily. Of course, we have to remove the inflammation or treat the inflammation for the pain to completely is gone. Again, the dyspnea had nothing, as you see, this patient has no problem with their lungs, but because every time the patient breathes, it cause pain. Now the patient become dyspneic and try not to breathe, or try to have a shallow breaths, because the shallow breaths will not inflate or filling the lungs. So this way, that's a strategy to decrease the restriction on the heart. Again, as far as ECG, we say that there would be a weak contractility. So you can see that in ECG, the cardiac output will be low, blood pressure will be low as well. And then you see symptoms of heart failure as well. Pretty looks like heart failure, but mainly had to do with the low cardiac output. Okay. That. There's two problems that can be a complication of pericarditis. Again, they're more just more of a restriction on the heart, and they cause pretty much the same symptoms. Low cardiac output, try to be compensated with tachycardia. The heart sounds muffled. The pulse is narrow because the systolic trying to compensate. You will see JVD here as a result of decrease or congestion of the heart, because again, the heart is unable to take all the blood that comes back as a venous return, which is normal. But because of the restriction, the heart cannot take the whole blood, so the blood will be congested in the vessels, and you'll see the JVD. Now we say JVD with no lung sounds, because this is not a JVD that you see in the heart failure, where you hear at the same time pulmonary edema. This is a heart-free JVD technically. It's congestion of the heart or the blood, because the heart is unable to receive all the blood due to the restriction. Okay, and we talked about the pulsus paradoxus. We explained that basically a change in or difference between systolic and diastolic. There is a difference between systolic and systolic during inspiration and systolic during expiration. But we say that this difference become higher when you add more restriction. The difference is due to the restriction that the lungs physiologically or normally apply to the heart. Now, in addition to that, there is a pathological restriction coming from pericarditis. Together will increase the difference in systolic blood pressure between inspiration and expiration. Again, you need to understand the classical symptoms, because if they're there, they confirm the disease. If they disappear, that indication that the treatment is good. Okay. Again, the classical symptoms here is the pleuritic chest pain, increase and gets worse with inspiration, and correlates with the pulse, because this is also close to the description of the pleural effusion. But pericardial friction rub, pericardial mean pericarditis. These are not necessarily classical, but you also see them in this patient. Diagnostic study again. We have the ECG as we. You don't have to. I mean, it's. You mean you need to understand. Okay, this is something you do in the skills lab. Basically, you need to be able clinically to measure it, not theoretically, but you need to understand the that pulses or the presence of pulsus paradoxus is something you would see, or it's an abnormal thing that you would see in cases like pericarditis. Okay, so um, the here's the other thing about the there was a question, I guess, Janice, about the ST elevation. Now remember when we talked about again CAD, we said that ST elevation is seen whenever there's a myocardial injury as a result of a clot or a complete or almost complete obstruction of one of the blood vessels of the heart or the coronary arteries. Now, as you see, the pericardium it covers the whole heart. So every time the heart contracts, the coronary arteries get squeezed between the inflamed pericardium and the heart. And every time that happens, that decreases the perfusion, and that's why you see ST elevation. So, but in case of CAD, when there's an MI, usually there's only one coronary artery that's obstructed, so you will see the ST elevation in one or two leads. But when you see the fused one everywhere, that means one of two things: either there's a pericarditis that's covering the whole heart and compressing every coronary arteries, and that's why you see the ST elevation everywhere, or that the patient has an MI in every single coronary artery they have, which is almost impossible. So that's why diffused and spread ST elevation in multiple leads means that there's more compression than injuries. Okay. Okay. Again, anything has to do with the heart from inside or outside, the best non-invasive procedure to do is echocardiogram. Again, the ST elevation that's caused by the compression of the pericardium or the inflated pericardium on the heart causing the ST elevation may also increase the level of troponin. But the level of troponin usually is not, it's not increasing like in MI. Okay, plus there's it's hard to find a patient with ST elevation and troponin elevated and have no chest pain that's from the cardiac origin. So that's another thing, that the pain that the patient has is not really cardiac pain. Okay, now how the best treatment after we give the patient the position first, of course. You need to give the patient some oxygen because of dyspnea and analgesia for the pain, but um, the best way or the ultimate treatment is basically to remove the fluids from the pericardium, and that's what we do with pericardium pericardiocentesis. As you see, synthesis keeps coming, which means removal of fluids from somewhere. This is we are removing it from the pericardium. So, and we talked about this procedure. Basically, it's after we position the patient supine position, and with the local anesthesia, we insert a needle through the thorax all the way to the pericardium, and of course under the ultrasound guidance, and then we collect the or aspirate the fluids from there. Always, every time you aspirate any kind of fluids from the body, it has to go to the lab for culture and analysis. Okay. If the patient's blood pressure allows, we give sometimes Lasix just to decrease the venous return and decrease the JVD. But if the patient's blood pressure is low as a result of low cardiac output, you want to be careful with Lasix. As far as pain, with position and NSAID should take care of that. If the infection is caused by bacterial, we have to also, of course, give the digoxin. temporarily treatment for, give antibiotics. Temporarily treatment for the restricted contractility is digoxin. The treatment, the pericardiocentesis is like magic. As soon as you remove the fluids, you'll see everything change. Cardiac output goes back to normal. Heart sounds again clearly. You can hear them. The ECG, ST elevation are gone, and yeah, everything just go back to normal, just with that simple procedure. Questions? So far, so good. Right. Yes. If the blood, yes, if the blood pressure and if the contractility is severe enough, until we have the patients ready to do the paracentesis, we can give dopamine. Dopamine, again, digoxin is available just to be given. Again, we have oral digoxin, we have IV digoxin, but IV digoxin is only available to be given one time or like one shot. It's not a drip. So if you need a continuous medication, that increases the contractility as a drip, then the drug of choice is dopamine. Okay. Yeah. Yep. What's the question?
Oh, I was asking about antibiotics,
Yeah.
and so after you drain, and then you send the culture, then you give the antibiotics to help prevent the infection to increase, or when does the antibiotics play a role?
Yes.
Like,
Good question. No, if in this case, because the paracentesis may take longer. Now, this is not a regular culture, blood culture, so we can't wait. What usually happens when you have what's always been reported, there's always a list for physicians. They look at the most common microorganism that cause a specific disease. Okay, or you can do broad spectrum. So in this case, no, you need to give antibiotics. Now, the antibiotics that we give in pericarditis is not the same as endocarditis. It's not the same seriousness. But the culture and the sensitivity is not only done just to see microorganism. Also, sometimes we want to know what exactly this fluid is, because this fluid could be cancerous. So if the patient has breast cancer, let's say a patient has breast cancer, this tissue or these fluids will also be looked at again for microorganism and also for the structure to see if it's a result of an active cancer in that area. But as far, just to answer your question, no, we start the antibiotic as soon as possible in this case. Okay. All right. Okay. Let's see. Now, as far as the valvular problems, again, we talked about the locations of everyone and their functions, and you need to know when they should open, when they should close, because this way you will know the problem, if it's stenosis or if it's insufficiency or regurgitations. And we talked about stenosis being problem during the opening where the valve is not completely open, and regurgitation is the valve is not completely closed. And as you say, it's the most important thing that you need to know, or just what you really need to know, is to know the location of the valve. You have to know them, and you need to know if they open during systole or diastole. Because as you notice, as far as pathophysiology, whether it's the stenosis or regurgitation, you'll find the same symptoms. Because in both cases, there's a blood backflow, either because it's not leaving or because it's coming back. In both cases, whenever the blood comes back, volume increases, blood pressure, the pressure increases, and then pressure moves back, causing the problem behind the ventricles. and it will mimic heart failure. Other than the only difference will be in echo, you will see that there's a valve problem and also the presence of murmur. Otherwise, the symptoms, they look pretty much like heart failure. Okay. And we mainly focus on the four: mitral and aortic and pulmonic and tricuspid. Okay, see. Okay, you must know that this is stenosis, apparently. Okay, I think I think what I have here on slides pretty clear on what you will need. And even the risk factors, they pretty much share the same thing. Okay, let me look for what exactly on. Okay, so you need to know again from the locations, and when there's a problem, where would you hear the murmur? So you must know that the mitral, for example, it's at level of apex. Now the word apex could be replaced with fifth intercostal space with midclavicular line. You must know that's mainly diastolic if it's a stenosis, because that's when the mitral should open. And I give you the acronym, should help you. Okay. And also, you need to understand the pathophysiology that apparently, again, whenever there's stenosis or regurgitation, pressures are high. Every pressure behind the problem will be high. So if you have a mitral, which is between left atrium and left ventricle, then the pressure in the left atrium will be high, and the pressure in the pulmonary circulation will be high as a result. And then that pressure will also travel to the right ventricles, will be high. So pretty much everything will be high, but the cardiac output is where the problem will be. Cardiac output will be low. And again, this is when there's a left-sided problem. And you will find that most of, again, the rheumatic fevers affects any valve. It just depends where the bacteria will stop. So these rheumatic infections, they don't target mitral or tricuspid. They just go. So wherever they stop, that's the valve that will be affected. Okay, so again, just like heart failure management with oxygen, diuretics, and low sodium nitrates for chest pain, calcium channel blockers. If there's atrial fibrillation, that's the care management, prevention of emboli using Coumadin, for weak contractility, digoxin, and if all that fails, then we have to do the surgery. Again, they all just follow one template for all of them. You'll find them all pretty much the same. The major difference between them will be the location of the murmur. No, this is not new. Okay. It's not new. We're talked about in class, and remember when I give you that acronym. Don't laugh. I can hear you. What do you mean? It's been there. It's on Sakai. I'm on Sakai. Okay. Again, here's a summary of all the murmurs of where you would hear them, whether they're diastolic and systolic, and their locations. Can get easier. All right. And we talked about the procedures. Okay, you have to understand the difference. Can you guys see this module? Okay. Okay. So you need to understand what I care about is the general idea and the general description. And the general description of the okay, I'm not sure why you didn't see it before. Okay, the general description of the procedures, mainly for your patient's teaching. We talked about the balloon valvoplasty. Again, remember, every time you see a balloon, when we talk about cardiovascular, it's a catheter that's inserted with the balloon inflated. When we get to the point that we need, it's a multiple inflation and deflation, just to squeeze something to the side and increase the opening. So in case of valves, that's what we do. In case of blood vessels, coronary arteries, that's what we do. So your patient needs to understand, and you need to be able to educate your patient about this. So if you have a patient who's going to have this, the question could be, again, because the focus here is the patient education, look for the statement that's inaccurate or look for the statement that's accurate. Which of the following indicates patients understands the procedure, or which of the following patient indicates further teaching is required. So this involves valvoplasty. Again, this depends on your understanding also of the word plasty and the presence of balloon. This is not a replacement um, of a valve. This is not even a repair of a valve. We're not cutting anything here. We're not suturing anything here. This is just simply using the balloon to increase the opening or the orifice of um, the valve, the specific valve. Okay. The other thing you must understand, again, from pathophysiology, that aortic valve is more serious than tricuspid, let's say. In general, we can say that the left side, or the valves in the left sides, are more serious than the valves in the right side. And we understand that because the left side of the whole thing that the work has to do. So a patient with severe aortic stenosis will definitely need a new valve, but not necessarily the case in a tricuspid with moderate stenosis, let's say. Okay, the other procedure is the concertomy, and that's where there's an open heart, of course, here. And this is where we have to, if there's any calcification, we can debride that, we can remove it. If the leaflets can be fused together, if the problem is, again, leakage because of insufficiency and so on. And we can basically, this is how we can increase the width of the orifice. Okay. The valve repair, again, the word repair, it's not replacement. Basically, this is usually done in case of regurgitation or regurgitation, for regurgitation, whatever. So, and that's why basically this is occurs as a result of weak leaflets or the annulus of the valves, of the smooth muscles. So we're basically just tightening, and so this way, it's not gonna fix the problem completely, but at least we avoid doing a whole valve replacement. And then the last thing is when we have to use the valve, and we talked about two different valves, and we talked about the differences between them, mechanical, where the patient has to have lifetime. So again, follow the red sign. Every time you see something in red, you need to understand that this is, something essential that you need to understand, because it will help you um, solve the questions. And if you go back after the exam and look at the slides again, you will notice that most of the questions that you had in the exam were highlighted in some way or another. Okay. We talked about the two major differences here. Again, patient education is important, that a patient understands if they're receiving mechanical one versus bio. We talked about the audible sounds that you hear it in mechanical. We talked about the long-term use of anticoagulants, and we talked about the post care, which is very, very important. The post care of the valve patients. These patients are not ready to perform their regular exercises. Where is it? Okay, this patient, they need rest. They cannot just go back to work the next day or the next week. Um, they are now at highest risk for endocarditis because they have a valve. So oral care and all the dental work should wait. Also, although they need an oral hygiene, oral care, it doesn't have to be something rough, because they may bleed. And then with a microorganism that's normally the normal flora in the mouth can become harmful, which is the blood, as you know. So the post-op care is very important. Especially you won't see, basically there will be an ICU until the second or third day, and then you'll see them after that with open heart incisions with wound care and so on. But you must understand and know all the post-op care for them. Okay. Okay. So here are more videos that can help you, and this is a procedure of valve replacement, new valve. Okay, questions? What is the question mark for? Oh, you have a question, I guess. Okay. Yes. Go ahead.
Can you send the PowerPoints for the modules to us?
I didn't send this one. Okay. Let me
Yeah,
just write
so
that
we
now.
can.
Okay. I will.
Thank you.
You're welcome. Okay, we're coming to that. Okay. The last one I'm just gonna go over is the vascular. Okay. Major, we talked about the you have to understand and know the difference between the arterial and the venous problems and how to differentiate, as well as the management. And that's pretty much it. But that's a lot. So you have to, because what is okay in one will be contradicted in another one. So for a patient with arterial, that's a patient you don't want to elevate their legs because you make it harder for the blood to circulate and you make the ischemia worse. While it's good for the venous to have the patient with their legs elevated because that enhances the drainage of the edema. Okay, so you need to know the differences. Also, the symptoms, the difference in the symptoms. One cold, the other one is warm. One with edema, the other one doesn't have edema. One with pulse affected, the other one the pulse is not affected, and so on. Okay, let's see. There's poor prognosis, and so patient with intermittent claudication, they rest, the pain is gone, good. If the pain does not respond to rest, then we're not good. Just like stable versus unstable angina, rest and not rest. Okay, talked about that. Okay, there's a poor prognosis there. So about diagnosis, again, as we did with the cardiac cath, but here we're doing it ultrasound without, of course, it's non-invasive. So you have to understand every test and every diagnostic test that we talk about, you have to understand it because it will come again and again and again. The reason I have ultrasonography, so for ultrasonography, Doppler ultrasonography, this is non-invasive. You must know that, and it's not an X-ray. Ultrasound is not an X-ray, so there's no risk for X-ray, especially if the patient is pregnant, and that goes with any ultrasound. And you should know that basically, that sonograph that's done in for pregnant women, it's basically ultrasound. There's definitely no X-ray there too. Okay, so anyway, the diagnosis of PAD and PVD, the presence of a clot in the in any blood vessel, whether it's arterial or it's artery or vein, it's through the ultrasonography. Okay, remember also that we talked about the ankle brachial index, and then how the difference in the blood pressure is changed because of because there's a clot. Okay, so whenever there's a clot or because there's hardening, I told you I have a patient one time with one hand or one arm give me systolic of 200, and the other one give me 120. Okay, so whenever the blood vessels become hard, it will take more pressure to occlude it. Now, this occlusion of the pressure or the increase for this pressure has nothing to do with the heart. It's not the pressure coming from the heart. It's because the blood vessels become hard. Yes, it's pretty simple. I have a slide for you how to do it. Okay, so after that question of the cardiac cath and visualization, now every time I see visualize, I'll put in red, so you remember that it's to visualize. Okay, this is in this slide you will see how to calculate the ankle and brachial index. Okay, I will post all these PowerPoints again. Make sure that they are on Sakai. Okay, so again, PAD, like in intermittent claudication, you will try rest. If rest doesn't help, we have some medication that we could use, and it depends how serious the problem is. And I go over everyone in detail. Let's see, some medication that you must know because of NCLEX. Okay, Plavix. You must know Plavix. Plavix should remind you of aspirin. Okay. It's pretty much the same, but it's 75 milligrams. It does a platelet aggregation. That's a good question. It's not common. If you have a patient who's taking both, yeah. And I highlighted that because it's an NCLEX alert. It's not in your book, but it's an NCLEX alert. So with the effects of Prolosic, yeah. Okay. So Plavix with omeprazole, that the Plavix become ineffective. So we have to double the dose sometimes, or that's if the patient must take omeprazole. If they don't have to, we just yeah. Well, again, it was just find out. Okay, let's see the other one. So Plavix is giving again any patient who has a stent. Any patient who has a stent, and whether in their heart, heart vessels or renals or whatever, they have to take Plavix for the rest of their life. Because this is tense, the platelets will come and aggregate and try to attack it, thinking that it's a foreign body. So the patient has to take Plavix for the rest of their life. Okay, the other one is Plital. Plital is a drug for the intermittent claudication when rest doesn't work. But what we found that Plital, it's doubled if it's taken with omeprazole. So we have to reduce the dose if the patient has to take both of them. And if all that fails and the patient now has, we could use TPA, which is we really don't. We rather do surgery than use TPA because of the complication. So I have the here's other management where we can do. Okay, first of all, just as we did before with the balloon, we can do the balloon. Okay, as you see here, or we can do the atherectomy, which basically the same idea, a catheter, but this time this part cuts part of the black, and it has a suction in it too. And or we do the cryoplasty, which is a new procedure basically where the balloon there's a balloon involved, and also there's through the catheter we can apply very cold air, and the whole idea of that is to shrink the black and get it together so it doesn't break off. This is the newest way. And if all that fails, then we have to do the surgery, which basically there's a black that's completely occluding the blood flow from the femoral artery down. So we get a part of the Salvinus vein, and we do a bypass. We suture here, so this is all gone, and then the blood now will flow this way. That's called femopopliteal bypass. Now, the care after is extremely important in this case, and the worst complication is if now the blood is not flowing. So, and that will be manifested by no pulse, plus all the 5 Ps that the patient will have. See, there's a lot of threads here. Okay. Okay. Read about Raynaud's phenomenon. It's another PAD. It's basically the patient. You must know that. Avoid all the patients teaching under nursing management is important. Huh? What's up? Oh, jeez. Like, what did I say? Okay. You guys know too much about each other. Confidential HEPA. Okay. Again, here's the differentiation between both conditions and okay, and the same thing for the venous. Okay, just by looking at this picture, you must know that this is a venous problem, not arterial. Okay. Okay. It's a lot of good stuff. All this good, really good stuff. You will appreciate it when you're done with the class. Okay. How many times we say this semester? Okay. Alrighty. We talked about the use of anticoagulants. Um, for the patients who cannot take anticoagulants, we have a solution. We have this what called inferior vena cava filter, which is pretty much like a metal filter that's inserted through through catheterization and left in the inferior vena cava. So for this is given for patients who or done for patients with high risk for DVT who frequently getting DVTs but cannot take Coumadin or any anticoagulants. So if there's a DVT now trying to go up and cause a pulmonary edema, it will stop right here. The blood flow will continue fine, but only blood clots will be caught and they will not go up, causing other problems, stroke or MI or PE. Okay, this is just a revision. I give this to you also because of your farm difference between Coumadin and heparin and what you look for and watch for. And again, here's the management of the patients with venous problems. Okay, questions? Okay. HET stands for heparin-induced thrombocytopenia. It is seen in some patients. It's not that common, but some patients after they receive heparin, even if they take it subcutaneous just for like 5,000 TID a day, just for prophylactic, we found out that it breaks down the platelets. It destroys the platelets. That's what it's called. So heparin induced, it's caused by heparin, thrombocytopenia, low amount or low number of platelets. So you have a patient. I had a patient actually one time. There you go. And always bring warm water with you to the class too. Or actually, we should make that available for you now. So anyway, I had a patient one time who was doing the dialysis, and we were giving just a little bit of heparin in their catheter because he didn't have um, uh, the fistula rate. So even a small amount, and then we noticed that his numbers start going dramatically going down. So if you have that, if a patient develops that, you have to quit heparin. They cannot take heparin. So again, it's a low number of or low account of platelets as a caused or induced by heparin. Okay. Yeah. Okay. Carrie, are you there? Carrie? Oh yeah. Well, I'm just want to say, okay. I'll let you start. I'm just gonna go and grab coffee quickly, and you are unmuted. You're on. Okay, you can talk now. Can't hear you. Okay, I'll be back.
I think I got it. You guys hear me? Okay, great. Is it possible to do to give me control of the screen so I can go through my slides as well, or no? I thought that was something that Nicole had done. Khalid, are you there? You left me. Thanks a lot. That's so nice. Okay, well, I would love to have my slides up for you guys so we can go over them. Do you guys want to go over diabetes first or fluid and electrolytes? Whichever's fine. Let me text him real quick and see. If not, well, we'll just have to get started. Okay. Um, electrolytes. Okay. Yeah, electrolytes is a little bit difficult because we didn't get a chance to go over everything in specific detail, but a lot of it is in the slides. So in general, you want to know the signs and symptoms, the normal values, causes of treatment, and then the special diagnostic stuff like for Chavostics and Trissos. The regulation of water balance is important through the kidneys, the hypothalamus, and the heart. I'll try not, I know we've been here for quite some time, so I'll try not to go over like everything in really detail, just highlight the main important stuff. So let's see. The composition of body fluid as far as intracellular and extracellular, it's important to know because it helps you understand like the different values. So sodium is one of the major extracellular ions. That's going to be in higher numbers, 135 to 145, whereas potassium is mostly an intracellular ion. So even small alterations, you shouldn't have a lot of it floating around in your blood. So the values are 3.5 to 5.0. And then any imbalances in that will cause severe problems, cardiac distress.
Okay, Carrie, you can now take over and show your slides. Carrie? Oh, sorry. Sorry, Carrie, are you there?
I'm here. Can you hear me?
Yes, I make you a presenter and there you go. You should take over now. You can.
Keyboard access mouse. Okay. Show my screen.
Yeah, show my screen.
Got it? Can everybody see?
Yep.
Let's see if I can go back to the conversation here.
You don't have to. You can see. But
Okay.
your.
I just want to be able to see if they have a question.
Oh, okay. Your screen is gone though. Can you show it again?
Is that? Can you see it?
No. Okay, now. Show it again.
Hey, I have to figure this out. I think it's that
Okay,
button.
now you're good.
Okay. All right. So I have electrolytes up first. They wanted to go over that. Um, okay. So we're looking at the composition of body fluid. Again, just major intracellular and extracellular ions are important. We'll go over the values and specifically with, is that okay?
Yeah.
The different electrolytes and their values and what you're going to see as far as the signs and symptoms and the treatment. So the first thing we talk about is fluid balance, understanding the different shifts in fluid, hydrostatic pressure, and stuff like that. For our electrolytes specifically, sodium follows, or fluids follow sodium. So when we get into that, this one normally talks about just the fluid spacing, as you just see here, first, second, and third, which we talked about in class. And then hypervolemia, hypovolemia, and to remember that there's the causes. So let's get to this one here is just major consideration is that the elderly and the very young are at high risk for electrolyte imbalances because of their total body percentage of water. Let's see, let's go over our imbalances because that's what you guys mostly need to know for the hospital, what you're going to see. So as far as fluid volume deficit, let's see. This is mostly just dehydration. So, and there's different causes. You can have fluid volume deficit because you don't have enough water. You can have fluid volume deficit because you don't have enough salt, or it can be because of both. So your signs and symptoms, depending on the actual cause, is going to be signs and symptoms of decreased fluid volume, decreased blood pressure, increased heart rate as a compensation, decreased urine output because of you're not perfusing your kidneys, you're dehydrated. So increased serum osmolality as well because it's more, your blood volume is more concentrated. Let's see, I have treatment, IV fluids. You want to identify the cause. Daily weights we talked about being the major indicator of fluid, the patient's fluid status. So for this one, you want to make sure you identify the cause because for a patient who's has fluid volume deficit because they don't have enough salt. Actually, let me see this here. No, so we talked about, let me go back up so I know what I'm talking about. Oh, here we go. This is what I was looking for. Who's at risk? Patients with altered level of consciousness, psych disorders, the elderly, individuals with unable to respond to their thirst regulation. We talked about that with the hypothalamus patients with brain injuries who can't drink and respond to their body's dehydration, and those who have electrolyte imbalances. Fluid volume excess, you want to understand that this is too much fluid volume, and this again can be because of different causes, hypervolemia, water intoxication, or too much sodium. So you're going to see signs and symptoms of fluid overload, which we saw a lot of this in heart failure, so I'm sure you guys are pretty familiar with that. For this one, it's important to understand it can cause dilutional hyponatremia, which we'll go over when we talk about sodium imbalances. And then treatment for fluid volume overload, we can give diuretics. You don't want to give IV fluids, obviously, if they're fluid volume overloaded. And then sodium restriction, because more sodium will help retain more water, and then daily weights, also to monitor the progress for treatment. If you're diuresing them, you want to see how much fluid they pulled off. So, like we said, we talked about this with CHF patients with kidney failure because they're not voiding all the excess fluid, and then psychological problems we talked about, patients with obsessive compulsive disorder. They're going to be drinking a lot, and they can cause hypervolemia and dilutional hyponatremia. So sodium.
So, sorry.
Sure, go ahead.
Yeah, it's mainly also because of the psych medication. Some of the psych medication they cause SIADH, and that's how they affected also. That's another reason. It's highly correlated with hyponatremia. Oh, okay, there you go.
Yeah, we were talking about fluid volume overload.
Okay.
So hyper and hyponatremia. Again, this goes with a lot of your signs and symptoms for fluid imbalances because the fluid follows the sodium. So you want to understand that it has an inverse relationship with potassium and that your normal values, which we've talked about plenty of times. It's important to know that sodium comes from it's found in a lot of your dietary sources. So let's go over just the important stuff here. You want to think of the brain when you talk about fluid or sodium imbalances, and because it affects your plasma volume, also affects acid base, and it's regulated by your fluid balance with your renin-angiotensin aldosterone and ADH. Let's see. So hypernatremia, again, you want to understand what are the signs and symptoms and the treatment for each electrolyte and what are the causes. So for hypernatremia, it can be corticosteroid use or renal failure. It's caused by different things. So if you have high sodium because of decreased excretion, you have high sodium because of increased sodium intake, or increased water loss, meaning it's more concentrated. So depending on the reason why you have hypernatremia, then that would affect how you're going to treat it. Signs and symptoms. You want to think about how this is going to affect the brain because the sodium affects the conduction of your neurons and they're easily activated. So if you have high sodium, you're going to have the seizures, confusion, signs and symptoms of fluid volume deficit. I'm sorry, fluid volume overload. And then your treatment would be diuretics to get rid of the extra fluid, salt restriction to prevent the retention of fluid, seizure precautions, and treat the underlying cause. Because again, we talked about you can have hypernatremia because of decreased excretion, increased sodium intake, and increased water loss.
Grace has a question.
Sure.
So yeah, so excessive thirst, not sure.
For hypernatremia, usually if they have, it can be like a symptom that they're really thirsty, but the thing is for hypernatremia, it would be delusional. If they have excessive thirst and they're drinking a lot, it would be delusional hyponatremia. Does that make sense? So I'm not sure if the question is as far as
Let's unmute
a cause.
Yes, okay, let's unmute her and say, okay. Go ahead,
I was
Grace.
asking about the psych meds. Is it because psych meds cause excessive thirst, which leads into
hyponatremia?
Yeah, I put that on a little bit ago. That's why.
Oh, okay. Do you want to answer that, Elmar?
Go ahead.
As far as psych meds?
Go ahead.
Well, I'm not.
Okay, go. Okay. Do you want me to answer?
Yes.
Okay. So mainly psych leads to what we call inappropriate syndrome for inappropriate ADH. It's SAADH, and with that, the amount of ADH is high. When ADH, what it does, it's antidiuretic hormone. So the diuresis will be low. As a result of that, the water retention will be high, and that leads to what we call dilutional hyponatremia. So the amount of sodium is normal, but because of the body is not losing urine as much as normal, now the concentration of sodium become low, and that's why the patient feels that way.
The question is, how is that related to psych meds?
Well, that's what psych meds, they're causing ADH, SIADH. One of the complication of some of the psych medication that they caused SIADH.
Is that related to the effect that it has on the brain, and it just affects the release of ADH? And
A lot of them, it's not clear yet. Most of the medication,
okay.
most of the psych medication, they work on the limbic system, but they, it's all correlated. So it is possible that it's also affecting the limbic system as well as the pituitary, and that would make sense. That's the only explanation. Is yes. So the increase of ADH, yeah, it's a neurogenic, called neurogenic ADH, SIADH.
And the point for the SIADH is that fluid retention causes dilutional hyponatremia.
Yes.
So that's, as far as electrolytes, that's what you'll have to understand, is the increased ADH causes fluid retention and then hyponatremia as far as dilutional serum lab values go. Does that make sense, Grace? Okay. So we talked about different causes of hypernatremia. So when we look at hyponatremia, it's the same. We have either dilutional from CHF, the increased fluid, drinking too much, freshwater drowning, or the ADH, which if it becomes excessive is that the SIADH, symptom of inappropriate antidiuretic hormone. And then decreased sodium intake, which is a little bit more rare because we generally have a lot of sodium intake. So in this case, the patient would be NPO or have nausea, vomiting, diarrhea would be more of the causes for that. So signs and symptoms, again, are going to be neurological, confusion, headache, seizures. So you want to know how to manage that, control the nausea, vomiting, correct the fluid electrolytes, have them on seizure precautions. So for this one, if it's caused by excessive fluid volume, you can do fluid restriction. If it's if they have, you can give 3% saline if it's and watch for fluid overload, because again, that's going to be pulling the it's a hypertonic solution, so it'll pull the fluid back into the cells. And then for SEDH, there's specific medications, but I think we're going over that with our. Are we going over that this next week?
Of what? The SIADH?
Yeah.
Yeah. Just focus at this point on mainly where would you see the electrolyte imbalances and the symptoms. They must be able to understand, to distinguish the symptoms. And in general, as you will see, that N goes with natremia, or sodium goes with the neuro symptoms mainly, because of the imbalance of the water and the shrinking or the overload of the brain cells. So whether cerebral edema or the opposite. Calcium, again with the muscles and the heart. Potassium, mainly with the heart. And what else did you cover? Magnesium,
of
course.
muscles.
Yeah, magnesium, muscles, and most importantly, the accessory muscle, the respiratory muscles. And yeah, that's pretty much it. And you see it a lot in renal failure. Most of these problems, if they're chronic, you see it in renal failure. But a lot of other problems can cause, yes. Okay, and also keep an eye which one is more serious and more significant. And of course, the one with the small range are more serious, because sodium, for example, was 130 or 145. That's a wide range, and symptoms don't show unless the patient's sodium is below 120. While sodium, we talked about this also, potassium 3.5 to 5, very, very small. So symptoms will start to show when the potassium is 2.8 or 3.2. Same thing with magnesium. it will show, because again, it's a very small. Calcium has a wider problems, and you will see, no, you will notice that in the hospital, as far as which one to be corrected and which one is not. So when you go and you see your patients with sodium of 130, you'll find there's no order. There's no normal saline 3%, because that's only is done when the sodium is severely low. If you give a patient salt in their food, that should take care of it. But if whenever you see the potassium 2.8, you right away you will see an order, either orally replacement or IV. Same thing with magnesium and so on. And you may see calcium a little low in patients who's in their 60s, especially as female. You see that osteoporosis, that's not something that's serious, should be corrected right away. So the seriousness, you must understand it. So if you have 4 different patients with 4 different electrolytes differences, which one should you see first? Again, don't right away answer and say, well, potassium. Well, that's might be the case, but look, you have to read the answer. I know some of you don't finish the statement. So you may have 4 different patients. One says potassium of 3.4 or magnesium of 1. Okay, now, yes, you knew that, well, potassium is serious, but it's not as serious at this point. You see how low it is. So make sure that you read. And as far as your lab results, the lab value that I sent you last week or a week before, this, you have to know them every time for every exam. That's the expectations in this semester, next semester, and 4th semester, and always. I'm done.
Okay, so let's okay, good. So let's look at potassium. Like we said, small ranges. You want to think about the heart when you think about potassium. Primary loss is the kidney. So if you have kidney dysfunction, you're going to have potassium imbalances. Potassium has an effect on your acid-base balance and your conduction system, and then secondary regulation with aldosterone. So this is example of hyper and hypokalemia as far as your EKG dysrhythmias, which
This
we've
is,
talked about many
yeah,
times in cardiac.
exactly.
So
This
that's
is a
kind of
classical piece of knowledge you must know always. You're gonna see it every semester.
So if you guys just think about the hypokalemia, you'll see the prominent U wave. I just associate it with hypokalemia because it has an O. I don't know. But and then the peak T waves for hyperkalemia, they're higher. So I think higher is hyperkalemia. I don't know if that helps you guys.
Yeah.
And then hyperkalemia. So again, we talked about the most common is going to be kidney failure. One important piece for you guys to understand is the salt supplements, because especially for your cardiac patients, salt supplements are usually potassium chloride instead of sodium chloride. So you want to educate them and let them know that as far as the dietary piece and as far as education electrolytes is salt supplements are high in potassium and they can cause cardiac problems. Also, we talked about potassium being the major intracellular ion, so crush injury or things that are going to cause the catabolic states, fever, acidosis, those are going to cause hyperkalemia as well. And one of the big things you'll get on NCLEX would be probably the spironolactone, which is a potassium-sparing diuretic. So just be aware of that one. Signs and symptoms for hyperkalemia. You're going to look at, it causes high excitability of your cells, so you're going to get, you can have cardiac contractility issues, the hyperreflexia, ECG changes. This is a mnemonic from your guys's, I think Kaplan or something, to understand the signs and symptoms. And then treatment. So you want to bind the potassium. You're going to give them KXLate. The number one thing you're going to look for after that is for them to have a bowel movement, because it binds it, and then they excrete it through the feces. Cardiac monitor. You can also do a temporary reverse. We talked about the potassium hydrogen ion exchange. So if you give insulin, you can drive the potassium into the cell, and then you want to give dextrose with that too, because normally these people you're not giving the insulin because of high blood sugar, so you don't want to bottom them out. You give it to push this potassium into the cell, and it's usually temporary. For patients like that, they probably have to be on dialysis. And this is a temporary fix so you can get them on dialysis. Potassium, stop the potassium IV or stop the dietary supplements. Check and see if they're taking salt supplements. Sometimes you'll see that as a cause for high potassium. And then sometimes you can give Lasix to cause the excretion of potassium. But you want to watch their fluid balance as well and their kidney function. Hypokalemia, nausea, vomiting, diarrhea, metabolic alkalosis. It's all kind of listed here, but you want to understand the signs and symptoms. You're going to think slow. Everything's going to slow down. You're going to have dysrhythmias. You'll have constipation. You'll have, you can have weakness and paralysis. So watch for your digoxin toxicity. That's another big thing for NCLEX with hypokalemia. So with this one, we talk about if they're low, you want to give them a replacement. And we did talk about all of the potassium, importance of potassium replacement. Never give it IV push, never more than 20 milliequivalents per hour, and never, if it's in a peripheral IV, you want to make sure it's diluted in at least like a liter of saline. These people, if you're giving potassium, you want to make sure they're on a cardiac monitor. Remember potassium, think heart. Just always go back to the heart and assess the IV very often because it's toxic to your veins. Magnesium and calcium, you always want to think muscle. You understand the normal ranges. Again, this one's a low one, so it can, with small narrow range, you can have imbalances and see some of these symptoms. So skeletal muscle contractions and blood coagulation. So a lot of times they can get hypermagnesemia from taking like milk of mag, and then also for chronic kidney disease. So this one, it helps stabilize the cell membrane. You can think about respiratory rest, cardiac rest, decreased deep tendon reflexes, lethargy. Just study the differences and understand that this magnesium and calcium usually go with muscle.
And DTR is a classic with magnesium. So I know that's part. I remember that when I was a student. What was frustrating is that they share some symptoms, but that's reality. That's because again, muscles, they need potassium, magnesium, and calcium. But trying to make it easy by thinking of what is the seriousness. The deficiency or changes in this electrolytes can cause a problem in different area, but can cause serious problem in some areas. So magnesium, I always think of deep tendon reflexes, and the rest are all related to muscle problems, not to cardiac dysrhythmia, for example. And potassium can go mainly with cardiac, with the heart. It still can cause problem also with the muscles. But as far as acute management at the hospital, that's what you have to be looking for, cardiac problems that has to do with the potassium. So, and then there was one point that when again the potassium, I hope that you all can now say that together. You never give IV potassium, IV push, ever, not even in your dreams.
Yeah, not even. And we talked about too that potassium IV push was actually given for physician-assisted suicide, so it's very lethal, and that, yeah, never ever.
And it's painful. It's not peaceful death even.
So let's continue with our electrolytes. We're talking about magnesium. So treatments, avoid magnesium-containing foods, really, for hypermagnesemia. A lot of times, and as far as in the hospital, when we're giving magnesium replacement, there's not that significant effects of hypermagnesemia. We sometimes don't even check the magnesium level before we give it, but you want to understand what the signs and symptoms are. And low magnesium is a little bit more serious because this one can it can cause cardiac issues. So for low magnesium levels, usually this is somebody doesn't get enough in their diet or somebody's on excessive diuretics. and can cause hyperreflexia, can
It's
be
mainly
seizures,
alcohol.
tremors. Yeah,
Alcohol.
alcohol. And then this is cardiac dysrhythmias. So you can get like torsades, which we kind of talked, I think we talked about a little bit in cardiac. And treatment, give IV magnesium, increase oral magnesium. And if given too rapidly, can cause cardiac arrest. So calcium imbalances, remember calcium has the inverse relationship with phosphorus. So you want to stay under the normal ranges, and that it's what it's regulated by. So this one's a little bit more involved. It's regulated by the parathyroid hormone and calcitonin. So parathyroid hormone will increase and calcitonin will decrease. It will decrease the blood levels of calcium. So calcium is important to understand. You need vitamin D to absorb it, and then it comes from dietary sources and also primarily from the bones. Let's see. The effects of calcium, again, muscles, nerve impulses, and blood clotting. It's part of the coagulation cascade. So hypercalcemia, anybody with hyperparathyroidism, and they talk about cancer, breast cancer, that they can have that as well. Calcium or vitamin D overdose, prolonged immobilization, renal failure is common in a lot of our electrolyte imbalances, and glucocorticoids can cause high calcium. So important are signs and symptoms. A lot of these in the hospital, you're going to see certain signs and symptoms. You're going to verify that with your lab values. So please remember your guys' lab values. Cardiac arrhythmias, lethargy, confusion. With this one also, calcium is a major component. People can have kidney stones. They have increased risk of DVTs because of their clotting times are affected. Bone fractures because it's from the bone. And then the effect on the muscles with the lethargy and the cardiac arrhythmias. So treatments, you can give calcitonin. Sorry, I don't know if this is actually, this is a calcium chelating agent, so it binds the calcium. No antacids. That's important as far as dietary considerations, because antacids are calcium carbonate. So if they have high calcium levels, it could be because of that. The weight-bearing activity keeps calcium in the bones. So if you help them facilitate weight-bearing activity, you can decrease the blood calcium levels. And then if severe hypercalcemia, you want to monitor the cardiac arrhythmias, and they may need dialysis. Low calcium, you're going to see in patients with immobility, renal failure. Some medications can cause hypocalcemia, postmenopausal women. Removal of the parathyroid also because of the way it's regulated. So it kind of makes sense, I think. This is important with calcium. Did you want to say something?
No. I was waiting for these two symptoms. Another classical thing that you must know too. The
Yeah,
symptoms of hypocalcemia and how you assess it and how you actually do it. Probably, I'm not sure if you learned that in health assessment though.
I think I had a slide on here. I thought I did, maybe not. So we talked about Diagnostics is the one for your cheek. So when you tap on the facial nerve, they have facial twitching. And then Trousseau's is if you decrease the blood circulation in their arm, usually like with a blood pressure cuff, you inflate the blood pressure cuff, they get that kind of gooseneck hand where their hand turns inwards towards them. I think I showed you guys in class as well. And those are, if you think about calcium and the muscles, the facial twitching and the hand contractures, can correlate that with the calcium and specifically low calcium levels. So treatment, increased vitamin D or IV calcium replacement. And then phosphate imbalances. Phosphorus is important. But usually if you correct the calcium, it corrects the phosphorus. So, excuse me. Okay, so phosphorus effects on the body. Okay, can you guys hear me?
Yeah. I just sent a
Okay.
short video on about the symptoms of hypocalcemia.
Oh, okay, that's great. Okay, where were we? Phosphorus. Okay. Inverse relationship with calcium can be from high phosphate, can be because of renal failure or tumor lysis syndrome. So also, if remember, calcium and phosphorus have the inverse relationship. So when you have hypocalcemia, you can have hyperphosphatemia. So then you're going to see Diagnostics and trousseaus with a patient who has hyperphosphatemia. So treatments fix hypocalcemia. Hypophosphatemia is low phosphate, can be from malnutrition, alcohol abuse, high levels of antacids. Again, that's because of the high calcium. And then the signs and symptoms: CNS depression, confusion, muscle weakness, dysrhythmias. Mostly, I would correlate it with the high calcium. And then give magnesium supplements. Decreased calcium is a treatment. And then IV phosphate. But again, watch your calcium levels. So any questions about electrolyte imbalances? You want to make sure, again, understand your normal values, signs and symptoms, how to treat it. You know? So let's try a quick review of the diabetes for this one. You need to understand the difference between type 1 and type 2. Some of your medication considerations with your oral agents and with insulin. You need to understand all of the education and teaching. The acute complications will be more for critical care, but your chronic complications and your education you want to make sure to cover. So let's see. We talked about diabetes as high blood sugar, so it can be abnormal insulin production or impaired insulin utilization. We talked about that. Glucose regulation with your from the pancreas. This is actually a pretty good slide. It shows you the that insulin is released from the pancreas, lowers the blood sugar. Low blood sugar causes glucagon to be produced by the liver, which raises blood sugar. So when we talk about type 1 and type 2 diabetes, we have either impaired insulin excretion from the pancreas or impaired glucose utilization or insulin utilization, which is glucose uptake by the tissues. And then I talked a little bit about signs and symptoms of hyper and hypoglycemia, just so you guys can understand what the symptoms look like. So hyperglycemia is excessive hunger, extreme thirst. This is your polyuria, polydipsia, polyphagia. Because if you have high blood sugar, a lot of times that's not getting into the cells to be utilized. So make sure that you guys can understand if the cells are starving, you're going to see those symptoms. I'm hungry, I'm thirsty, your cells are starving. And then hypoglycemia, you're going to see the dizziness, irritability, shaky, anxiety, tachycardia. So those are important to understand as far as teaching and for your patients with diabetes. You want to make sure you understand low blood sugar reaction and to teach them how to see that. And if low blood sugar goes untreated, it can progress to seizures, coma, and death. So metabolic syndrome we did talk about, but it's basically a condition that increases their risk for type 2. And let's see my typo there. It's just a series of like high blood sugar, high cholesterol, central obesity that increases their risk for diabetes and heart disease and stroke. So they're saying that these people are a higher risk. Okay, so we into type 1 and type 2. There's other types of processes that can cause high blood sugar. Gestational diabetes, there's prediabetes, secondary, and diabetes insipidus, but those are, I think that's covered when we talk about we'll talk about that next week. Theories to link diabetes, there's not really a cause, so we're not sure exactly what causes the pancreas to quit producing it, besides it's an autoimmune disorder, and then why the cells decrease their sensitization could be viral or environmental causes. So the major part is to understand what the disease process is and how to treat it. So type 1 here, we have B cell destruction, which is the autoimmune, usually juvenile onset, and that these patients with type 1, they start seeing signs and symptoms once their body has stopped producing at least like 90% of the insulin, and then they have when they stop producing insulin, they can end up having diabetic ketoacidosis. They start trying to break down fat and energy from other sources, and just understand that as generally associated with type 1. Manifestations, your classic polyuria, polydipsia, polyphagia. These ones will have weight loss versus type 2, which would be, usually you see them have weight gain. And then again, they become insulin dependent. So their body doesn't produce insulin. Sometimes they can have either their injections, they can have the pump, and they can be taught to manage that. So we'll talk about type 2 before we get into the diagnostics and treatment. Type 2 is the decreased sensitivity of insulin receptors at the cells. So the insulin production is usually normal, but the utilization of glucose is impaired, so they have high blood sugar as a result. This is usually family history or obese individuals. It's usually adult onset, or has come about like after individuals over age of 35. And then these individuals, because they still have some producing insulin, they can have higher blood sugar levels without the production of ketones or acid, like the type 1, and then they can have the hyperosmolar coma. So again, these are your causes. Manifestations. Usually this is more of a gradual onset, like type 1. A lot of times they find out acutely that they have type 1. They have weight loss and these extreme symptoms, and they get hospitalized sometimes as their first diagnosis. And then the manifestations of type 2 can be more gradual, chronic, just I'm more tired, I have these wounds that are not healing, my vision's going blurry, and then sometimes it gets diagnosed as they just a routine checkup and they realize they have high blood sugar. So treatment for them, that you want to prevent chronic complications, which is part of our major teaching for these individuals, and they can be on oral medications, and eventually if it becomes severe and progresses, they may end up being insulin dependent as well. And again, we talked about because they their body produces normal amounts of insulin, or sometimes a little bit less. It's a problem more at the tissue sites, that sometimes the pancreas will overwork and kind of die out, and then eventually they don't produce insulin anymore, so then they're essentially treated as a type 1 at that point. But it's mostly because they have a complication of their type 2 diabetes. Lifestyle adjustments are really important for your type 1s. I'm sorry, type 2s. So diagnosis, we have the fasting glucose, the random or the 2 hour glucose 2 hour glucose tolerance levels. And
All right.
here's our A1C, plasma glucose, and your oral glucose tolerance. And these are your normal values, prediabetes and diabetes values. So A1C of greater than 6.5 is indicative of diabetes. Your fasting plasma glucose greater than 126, and your oral glucose tolerance, and that's your 2 hour oral glucose tolerance test above 200. So what they do is they drink a sugary drink, they check their blood sugar after 2 hours, and normally you can metabolize that blood sugar and have blood sugars less than 200. But if you're diabetic, a lot of times that's impaired, so greater than 200 would be your oral glucose tolerance. So make sure you understand the diagnostic levels. And this, some of you guys didn't understand that glycosylated hemoglobin level is your A1C. So please correlate those two because it could be either or as far as the answer, your A1C or your glycosylated hemoglobin. And it shows your percentage of average glucose, and that's because it's the glucose that's attached to your hemoglobin molecules, and it's usually over 9,200 days. And anything over 7 is like let's see, 6.5 or 7. And this I put here to show you guys how A1C is correlated with your estimated average glucose. So if you look at this chart, at about 7% A1C, you're at 154 milligrams per deciliter of glucose. So your goal for diabetic patients is usually less than 7, and that's controlled diabetes. Treatment. It's usually done at a specific interval. Like you can check if you check it once, it's an average over the 120 days for the life of those red blood cells. Does that answer your question?
What was it?
I'm not sure. It's
Oh, do you mean, Alicia, do you mean do we do it every 90 days or 20 ever 90 over? Okay, no. We do it just whenever we suspect that there's no good control. So at the beginning of the diagnosis, we'll do it. And then, so what these patients, they do, they have to keep a record of their blood sugar, and they come once a month or every other month. And most new machines right now, they have a SIM card. So we take it, we run a computer, and we look at the number. Now, if you see that the numbers are not being controlled, then we'll look at AUC. But no, we don't do it every 3 to 4 months. It depends on the patient. Sometimes you need it once a year or every other year, or at any point where the number starts to go up.
It's a indicator of how well controlled they are, because sometimes you can get patients who are managing their diabetes, and remember when they have their blood sugar logs, it's usually hopefully before breakfast, lunch, dinner, bedtime, and you can get an idea of how their blood sugar runs throughout the day. But if they're not good record keepers or they don't check it, sometimes you can do an A1C to say, look, you're not, your numbers here are marginal, but your A1C actually shows that you're pretty high. So we need to do some adjustments to your medications to get you better controlled. Does that make sense? Okay. And for this one here, this is your insulin. So we talked about insulin as a management required for type 1s, sometimes for type 2s. You have your rapid acting, short acting, intermediate acting, and long acting. Please understand your peaks and durations for them, and the indications for that. So if you give a rapid acting, make sure that they have food available, and that if they have, you want to make sure to check their blood sugar pretty closely to the time that you're actually going to give it. And then your rapid acting and your NPH, those are the only two that you're going to mix together, R and N. That's your clear and your cloudy. And then your long acting usually has no peak, but you give that as your basal insulin. And we talk a little bit, a couple of slides later, about basal bolus. insulin therapy, which is your long acting, which covers your baseline glucose level, and then your rapid acting, which covers usually before each meal. And that's generally how we mimic the function of the pancreas. You have your basal, and then whenever you eat, you increase your insulin to cover that meal. Insulin teaching is important. We talked about rotating injection sites within one particular site. It's not necessarily that they have to rotate between the legs to the arm to the abdomen, but they don't want to hit the same spot because they can get lipodystrophy if they hit the same spot each time. And then rolling your insulin instead of shaking it. Also, we talked here about insulin can be left at room temperature. The ones that are in use, the extra ones, can be in the refrigerator. And it's usually only 28 days. The fastest absorptions in the abdomen. Also, as far as teaching and exercise, we talked about that in class about not using the arms or the legs if they're going to be exercising. We also talked about making sure that if they are exercising, that they carefully monitor their glucose levels because we don't want them to have hypoglycemia as a result of exercise. And I think it was a little bit unclear. I want you guys to understand that we give insulin to lower the blood sugar, so we don't want them to have peak levels of insulin at the time that they're exercising, because then they'll have low blood sugar reactions. Does that make sense? I'm hoping so. Okay, as far as indications, like when the patients are exercising, you want them to be very aware of their blood sugar levels. So check their blood sugar before, during, and after, because when you're exercising, you're also using your blood glucose storage. You know, you're utilizing your blood glucose for energy while you're exercising. So if you give insulin, you don't want it to peak while they're exercising, because then they'll have low blood sugar reactions. They're one, you gave medication to lower blood sugar, and two, they're exercising, which also lowers the blood sugar. So that's why they need to pay close attention to blood sugar before, during, and after. If they're gonna, their blood sugar is low, they need to have like a snack or something after to make sure they don't go too low. Okay, so this is the basal bolus therapy we talked about, and you see this requires a lot of teaching for them and compliance. They're going to be injecting themselves at least 4 times a day. Complications of insulin therapy, the Somogyi effect and the dawn phenomenon. So important to discern the two. Both of them have high blood sugar in the morning, but for the Somogyi effect, you need to be able to check the 2 a.m. blood sugar, because the reason why they have low blood sugar, the reason why they have high blood sugar in the morning is because they had low blood sugar at night. So please remember that for Somogyi effect, you want to check the blood sugar at 2 or 4 to see if they have hypoglycemia, and then which would be the reason why they have high blood sugar in the morning. And then dawn phenomenon is usually because of the counter-regulatory hormones that they have high blood sugar, but they do not have the low blood sugar at night. And teaching for that, if they're having hypoglycemia at night, you can increase the bedtime snack or lower the bedtime insulin. Does that make sense? So you don't want them to have low blood sugar at night. You either reduce the mealtime insulin or give them a bedtime, like a light bedtime snack, so they don't have low blood sugar. And that usually has better management. And then for the hyperglycemia in morning that doesn't have low blood sugar at night, sometimes you can give them a little bit more of a basal insulin at night to cover the high blood sugar. As far as oral agents, usually this is only type 2s because you're going to be working with the function of the pancreas or the liver to reduce the blood sugar levels. So we talked about your blockers, your secretors, and your sensitizers. Please try to review these a little bit. The biggest things I think here is the chance for hypoglycemia, and don't skip your meals. especially if this like sulfonylureas is going to increase the insulin production. So they have high chance of hypoglycemia, and you don't want to necessarily combine that with a metaglutinide because that one's going to also increase the production from the pancreas. Does that make sense? It's like double dosing, I guess. So sometimes your combination therapies can be to one, increase insulin production, and two, to increase the sensitization. Okay. So your biguanides, metformin, has a lot of things that it works on. It increases insulin sensitivity. You guys can kind of read this here. Decreased glucose production by the liver. It doesn't promote weight gain, which is nice, and it has less of a chance of hypoglycemia. But these, you shouldn't take it if you have liver or kidney problems.
These are
And
for
then,
type 2, not type 1, Janice.
yes. Remember, all oral agents,
And she has
type
a
2.
question.
It doesn't make sense to give an oral agent to a type 1 diabetic because of the fact that if their pancreas isn't working and you're trying to increase insulin from the pancreas, it's not going to do anything. Does that make sense? And there's no problem with the sensitivity at the tissue site because the problem with the type 1 is that they don't produce insulin. So those ones are specifically insulin dependent, whereas a type 2 could be because they don't produce enough from the pancreas, or could be because they're decreased sensitivity at the tissue sites. So we have different medications that work at different sites to hopefully reduce the blood sugar levels and prevent the chronic complications for type 2 diabetics. Yes, all oral agents for type 2. And then please remember, it's been multiple times that we've discussed the metformin. So that's one of your biguanides, and we talked about taking it with IV contrast and regulating your kidney function, making sure they have good kidney function. Your alpha glucosidase inhibitors are starch blockers, so that usually works in the intestines. Okay, it's going to prevent the reabsorption of carbohydrates in the small intestines. One of the side effects is the fact that they have flatulence or excessive gas, so that's an important teaching point for them. It doesn't have a lot of hypoglycemia because, again, you're just preventing the absorption of carbohydrates that eventually turns into sugar. Now, TZDs, these are sensitizers. I don't know, I just think Z sensitize. I don't know if that helps you guys. But let's see, improves the insulin sensitivity and transport, causes weight gain, increased cholesterol, hepatotoxic. So other drugs that can affect your blood glucose, remember, beta blockers can mask hypoglycemia symptoms of tachycardia because it blocks beta 1 on the heart, so you don't see tachycardia if they have hypoglycemia. You guys understand that? I hope so. Okay, your
Are you guys there?
I hope they're there. Okay.
Oh, okay.
Are you guys have any questions? Am I going too fast? Okay. I hope it was pretty clear in the presentation. Okay. Thiazide diuretics can potentiate hyperglycemia by inducing potassium loss. So just side notes to consider. Incretin are your intestinal hormones, increased insulin synthesis and excretion. So this one, it's inactivated by the DPP4, which is why it's actually one of our treatments. So I think that's this one, your DPP4 inhibitors. And then your incretin mimetics are, they're simulate GLP-1 in type 2 diabetics, which is part of this over here. I don't know if you guys can see that. Well, I don't know what I'm doing.
Yeah.
Okay. These are, I think, newer therapies, but It helps. They're actually injections, sub-Q injections, but they're not used in type 1. Does that make sense? So it helps suppress glucagon, increases satiety, and slows gastric emptying for type 2 diabetics. Another important medication for diabetes is glucagon, which doesn't lower the blood sugar. It actually treats when would it be prescribed? The incretin, is that what you're asking? Usually first line therapy is going to be your oral agents. The incretin, I think, would be for more patients who are uncontrolled or we're looking for alternative means to help control that. Sometimes finding the right therapy for these patients is a little bit of a process. So, this is, I just want you guys to remember that glucagon treats hypoglycemia. It doesn't lower the blood sugar. This is actually for a patient who has like a low blood sugar reaction. They can either inject themselves intramuscularly. They have like gel. They have glucose tablets. These are all to raise the blood sugar levels. Any person that's diabetic should always have something on hand for low blood sugar reactions in case they don't not around food or anything. So important teaching points to teach to recognize the signs and symptoms of hypoglycemia and when they should be giving these injections. In the hospital, you can give this IV or IV D50 to raise the blood sugar levels. Diet modification. So this is as important as far as teaching your diabetic patients to, especially type 2 diabetics, to modify their diet to decrease their glucose levels and try to keep that under control. There's a few different things that have been developed, like carbohydrate counting, glycemic index, my pyramid. They're all different diet considerations for diabetic patients to help lower their blood sugar levels. You want to have them limit their alcohol. The My Plate method is the picture right here, just to help them understand different portion sizes and diet regulate, to watch their diet. Exercise, importance of checking their blood sugar before, during, after. Helps increase insulin sensitivity at the receptor sites. We talked about considerations when they're taking insulin. Helps contribute to weight loss. Again, this is important for type 2 diabetics, specifically because it helps increase insulin sensitivity and then lowers blood glucose. Blood glucose monitoring. Patients need to be educated on the importance of blood glucose monitoring. It helps them to be able to manage their diabetes. They need to know how to signs and symptoms of hypoglycemic reaction, diet considerations, exercise, and when they should be checking their blood sugar in relation to all of that. So before their meals, before and after exercise, before they take their medication. Obviously, they don't want to take their medication if their blood sugar is really low. And then compliance. If you realize that a patient has compliance issue, maybe they need to be educated on blood glucose monitoring or when to do it. So I'm going to skip the acute complications and the treatment and management of that.
Okay, see if they have specific questions. I mean, we almost we went like over like an hour over.
Do you guys have any specific questions?
See if you need to go. See if there's a need to go over everything. You guys want, how many slides you still have? There's about another 9 slides or so.
Yeah, we're just chronic complications and sick days education. So the important thing is for I do sick days that they need to continue taking their medication, because a lot of times when they're sick they could still have high blood sugar levels, and if they can't keep fluid down, they can increase their intake of non-caloric fluids. So hopefully they don't get a lot of hyperglycemia, but sometimes they may need to be hospitalized because it can potentiate like ketoacidosis and if they're not able to take their medication. So, okay, chronic complications, we look at the microvascular and the macrovascular complications, and then specifically diabetic foot care. So, because of the high glucose levels, it damages the endothelium and all of the vascular cells in the entire body. So, a lot of complications, we look specifically at diabetic retinopathy and the effect on the kidneys. It's actually one of the #1 causes of blindness for patients with diabetes, and also kidney disease can lead to renal failure because of the damage to the nephron. It also affects, like I said, every body system. It affects the skin. They can have different skin changes in the pigment, which is kind of like a new thing that they've been studying, that this dark pigment skin can be because of the insulin resistance. And then the other one is more specific with type 1, where they have the shiny skin with red blotchy. You can see the blood vessels under the surface of the skin. Those are your peripheral vascular disease, and they can have the gas effects on the stomach, sexual dysfunction, neurogenic bladder. Again, it affects different body organs, and sometimes that's one of the things that they can have decreased low blood sugar awareness because it affects the nerves and the, let's see. I talk about nerve damage and how it decreases the sensation. I think I did up here. Yes, neuropathy, sensory neuropathy in the extremities, and they can have hypoglycemia unawareness because they don't sense the low blood sugar. Okay, this is just the overview. It's kind of like a total body problem: stroke, hypertension, skin problems, neuropathy, nephropathy, erectile dysfunction, peripheral vascular disease, coronary artery disease. Foot care is important. They need to be checking their feet. We talked about high risk for ulcers because they have decreased circulation and PVD. They can't feel anything down there, so they have a long time healing, especially with chronic hyperglycemia. They don't heal their wounds very well, so they're highest risk for lower limb amputations because of chronic complications of diabetes. Talked about nail care and podiatry, proper fitting shoes. Again, those are all teaching points for your patients with diabetes. So different diagnostics to test for neuropathy. They have the monofilament test, which is the picture at the top. If they can't feel that, sometimes they have decreased sensation, and it's indicative of neuropathy. PVD, ankle brachial index, which we talked about before. The checking the creatinine and the if there's albumin in the urine can be an indicator of kidney function. Different cardiovascular problems. Check their blood pressure. High risk for CAD, so check their lipid profile. Eye exam for retinopathy, hearing loss. Check their hearing. Monitor for depression. A lot of times, chronic disease and the management of it can cause depression. So, treatment goals: prevent low blood sugar reaction, treat the hyperglycemia, prevent chronic complications with tight glycemic control, lifestyle adjustments, and then, for type 2, healthy diet and weight loss. Any questions? I hope that helps point out some important stuff. I think everybody's asleep.
Well, it's kind of almost like as long as the actual lecture. Let's see. There's we don't I don't know the answer for this question yet. The percentage, because the exam is not done yet. Know the groups. Many of the groups. But medication like glucophage, which is metformin, again, that medication you see it over and over and over. So I would say for that one, yes, you need to know. But if you know the as far as groups and the difference, mainly the general mechanism of action of each group, you'll be fine. Yes, you always get both names. Yes. Okay. Questions? Gary, you're done?
I think so.
Okay. They did you add practice questions? You did, right, for diabetes?
I did, yeah.
Okay. Questions, you guys.
Okay, study hard, guys. There's a lot of stuff to cover on this exam, so
You'll be fine. Okay. I will send you the link as soon as this was the longest. The same 30 questions like every time. Same everything, and I won't go around this time. I'll just sit still. Probably won't be there actually. Just eliminate risk factors, right? Eliminate me. No. All right. Now you can go study, and I'm gonna go and run now. Okay. See you on Tuesday. You're welcome. Okay. Bye, Kerry.
bye.
Okay. I need to end this.